Welcome to the Ticktective podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. Dr. Stephen Phillips is a Yale-trained internal medicine doctor who specializes in zoonotic diseases like Lyme, Bartonella, Babesia. He also is the co-author with me of the book Chronic, and he is the doctor who I am constantly talking about, who saved my life after a dozen top doctors failed me. He is one of the most brilliant and wonderful people that I know, a very, very dear friend and family member to me at this point. And he is also on the scientific advisory board of the Bay Area Lyme Foundation. Can't say enough good things. And I am so excited for you to hear everything he has to say today. Thanks for joining us. Well, here we are back together again.
The dynamic duo.
The dynamic duo. For anybody who is not familiar with my very brilliant and esteemed doctor, brother, friend, all the things in life, all the things we're so lucky to have met. I'm also co-author.
Yeah.
We haven't done enough of these lately. One thing that I have been wanting to talk to you about, and I know you've done this before, but I'm excited for you to bring this information to a bunch of new people who may not know it, is a couple of questions on Lyme basics and why people should care about Lyme and have this as part of the differential if you have chronic, autoimmune, weird symptoms, whatever it is, neuropsych stuff.
The basic answer to your first question is, why is it important? It's really important to get to the cause of a mystery autoimmune illness if you have any chance at all of helping people in a real way. Current paradigm is all about symptom suppression for the rest of people's lives. And where does that get you? It gets you with hip replacement surgery, increased risk of cancers and other infectious diseases, and monthly infusions, and huge medical bills that drive up costs. So
what are the monthly infusions?
Immunosuppressant drugs kind of dole out little bits of decreased suffering to people. They improve quality of life, but at what cost? You know, they're suppressing the immune system. We're blessed with this amazing immune system that keeps us safe throughout our lives. And it's always been my feeling that we should augment the immune response, make it stronger, do all the things that are common sense remedies. Whereas if you have an infection, you should make the infection weaker so you can overcome it. And there are a lot of ways to do that, but the current paradigm is the exact opposite. It's like, let's suppress the immune response. And they wanted to do that with me, which is, you know, it's in Chronic, and I've spoken about this so many times. I had 3 top rheumatologists, and they were begging me to go on various immune suppressive drugs. There were TNF inhibitors and steroids and other kind of carcinogenic immune suppressors. And I adamantly refused because I knew I had an infection driving my autoimmune condition. Nobody knew what was going on. I saw dozens of doctors. So this big black hole in medicine isn't just happen to me. It didn't just happen to you. There are a lot of people that fall off the map with these mystery conditions, and knowing what's out there in terms of these chronic infections is intimately related with the path toward getting better.
So what's the problem with there's a lot of controversy about Lyme. Some people that are watching this will know that there's controversy. They won't know why. And it's kind of important to just take people a tiny bit through it. For example, we don't have a good test for Lyme. What would you say the odds are of getting an accurate Lyme test? And what is the value of a clinical diagnosis?
I think there's too much emphasis on just Lyme. It's an oversimplification of the infections that are out there, because there are lots of infections that we carry, and it's the cumulative effect of them that really kind of make us sick, and the cumulative effect of other things that kind of make us well. To look at these kind of one cause only situations, the bodies are so complex and we're exposed to many, many things. I mean, it's kind of counterintuitive that we're like walking little zoos, and we have these microcosms of microbes within us that we live with, and we're in balance with them on a regular basis. And this is all not controversial. Like, this is well known. The perfect example of that is the microbiome. Under good circumstances, the microbiome lives with us and coexists peacefully. But if we experience immune dysregulation, that same microbiome attacks us. There's friendly bacteria. There's no such thing as a friendly bacteria. There's no such thing as an evil bacteria. So when I look at Lyme, I like to think of it as collectively. And in the book, we call it Lyme Plus, because Lyme is technically Borrelia burgdorferi, which is a spirochete. There are many species and strains of this bacteria. It's present worldwide, and the tests are poor. And
How poor?
so a published meta-analysis of 8 studies showed that the sensitivity is around 50%. So it's like a coin toss. And the Lyme antibody tests are very much geared up to Lyme arthritis, which is a relatively small subset of Lyme disease. So patients with Lyme arthritis almost exclusively have very, very positive Lyme tests. We're talking positive Lyme ELISA, which is a screening test, and positive Lyme Western blots. And they frequently have like 8 bands on the Western blot. But it's like defining the iceberg by its tip. It's a very dangerous thing when you define a large mixed population by the stereotype, and then you miss the more common presentation. Presentations of Lyme are not Lyme arthritis.
Yeah.
And most people with Lyme don't get Bell's palsy. And that's just the way it is. Most people have like a rheumatologic presentation. It can present as something along the lines of chronic fatigue, ME/CFS. They present as sometimes things like multiple sclerosis. There's some autoimmune conditions, but really most of the hardcore autoimmune conditions are not so much Lyme. Most of the hardcore autoimmune conditions fall into these other infections, Bartonella being among them. That's the one that really got me. I mean, I had Lyme in med school. That's when I first got Lyme. And I never developed any autoimmune conditions at all. Nothing. I had body aches and was tired and heart palpitations and tingly feet, but sleep disturbance, but that's about it. I never developed any of these conditions that I have now. And Bartonella just completely wrecked me. And why did it wreck me, and why do other people have asymptomatic? So the other thing that people should know is that asymptomatic infection far and away is more common than symptomatic infection with these microbes.
Is that with Lyme, Bartonella, both of them?
Yeah, both of them. And even with the ones that are, people think kill you, everyone hears about Babesia killing people rapidly and anaplasmosis killing people rapidly, and they can, and Lyme kill people rapidly too, and so can Bartonella, but most of these infections are asymptomatic. If you just randomly test people in the New England area, like Boston, Cape Cod area, 3% of the population tests positive for Babesia, and they don't have any history of Babesia that they know of. And throughout New England, 11% of people test positive for Lyme. These are healthy people, and the Lyme test being as insensitive as they are, if 11% are testing positive and they're roughly 50% sensitive, does that mean 1 out of 4 people is walking around with Lyme and they don't even know they have it? And then what should be done about it? And brings all these other ramifications. The statistics are similar for Bartonella, and it's not just in Connecticut; it's around the world. Bartonella is probably spread by more bugs than any of the vector-borne infections.
What is it spread by?
It's stereotypically spread by things like lice and fleas. There's been documentation of spread by biting flies, and even spiders and ants in case reports have been published to be able to spread Bartonellosis.
Somebody said to me yesterday that mosquitoes can spread Lyme.
The question is, at what efficiency can they spread them? There's one animal study that I was aware of where they demonstrated, I guess one of the animals turned antibody positive. It was not symptomatic, but turned antibody positive, I think, after mosquito exposure. Yeah, I think it's possible. I mean, look, I got sick after spider bites. After my first Lyme, I never walked on the grass again. I mean, I did all my sports on pavement. I was a tennis player and a jogger and all these other things, a skier, and that was it. I was never hiking again. And I got sick while I was sleeping in bed, got spider bites in the middle of the night, never thought to treat these with any type of antibiotic, and 2 months later my whole body exploded with this rapidly progressive arthritis throughout the whole body. The question is about the efficiency of the vectors. Vectors are these bugs, and some vectors are really, really efficient. Like ticks are pretty efficient vectors, but they take, some non-linear but some extended time to transmit the infections, and there's not a definitive like 0 point from a tick bite. We don't know, like, is there any point that the tick is not infectious, but it's nonlinear, meaning it just goes up like this. Like the longer the bite is on, the higher the risk of an infected tick bite.
Sure.
You really can't identify at any point where it's strictly zero.
So ticks can transmit all these things at once, is sounds like that's what you're saying.
Ticks, like Nicole Malakowski, our friend, says, ticks are, nature's hypodermic needle. So can lots of bugs. I mean, I've had patients for years before I got sick swear to me they get sick by spider bites, but I'd never seen it in print anywhere until there was that article by I think Ed Breitsch, where a family of, I forget how many in the family, but several of them dropped out one by one by these mystery neurologic illnesses after getting bit by spiders in a spider-infested house.
I guess it's not all that surprising given how many stories like this we hear. Not everything's being looked into. It just seems like this is kind of the black hole.
Not everything. It's kind of like the understatement of the world.
Yeah, exactly.
There's so many horrible things going on that are blatantly ignored. Yeah, it's not being looked into. Yeah, for sure. Not every. Yeah, science is this. It's such an imperfect system that's so heavily corrupted and so many financial motivations above all else.
I hear from people all the time who want to know about the way you treat. So, for example, do you treat an actual plain old tick bite before symptoms? You see the tick, if you're lucky, and we should say very few people actually are lucky enough to see a tick bite. They often are just very elusive and tiny and they hide. Do you go and get antibiotics if you are a patient of yours?
Yes. I mean, we treat tick bites with 2 weeks of doxycycline. A lot of people will say, well, 2 weeks of doxycycline. Well, there's two things. One thing is that one common tick bite treatment is 1 dose of doxycycline. So the question is, does that work? Have you ever seen that fail? What's the science behind it? I've seen it fail over and over again. I think it's a horrible treatment. I think it should never have become popular. The study that supported it was a highly flawed study. They just showed that it prevented rash for a short period of time. They didn't follow people up long enough to see if they developed Lyme disease. And preventing a rash does not necessarily equate with preventing the illness.
Right.
Plus, it was a 1 dose of doxycycline, which is going out of the body relatively quickly. And patients, need some. There's always like antibiotics have a certain kinetic where they need a certain amount of concentration for a certain period of time to be effective. And 1 dose does not cut it at all. And doxycycline, just so people know, it doesn't really effectively even kill Lyme bacteria in the test tube. It doesn't do it. It kills like 90%. But we have had good luck with 2 weeks of doxycycline. And what is surprising to some people is that I've never seen anybody come down with babesiosis who's done 2 weeks of doxycycline at the time of the fight. And, doxycycline is not a treatment for babesia. So how does that work? Doxycycline has some antimalarial activity, and babesia is a cousin to malaria. And some people who've traveled to different parts of the world may have had experience with some parts of the world, there's kind of doxycycline susceptible malaria, and doxycycline can, or at least in the past, has been used for malaria prophylaxis. It's not really used now so much because so much has gotten resistant. But it's just a perfect example of like an ounce of prevention is worth a pound of cure. Like even though it has like this much anti-malarial activity and then by extension anti-babesia activity, if you give it as prophylaxis, it's enough. And if you give it as treatment, it's not. Like doxycycline won't treat babesiosis, but in my experience, we've never had somebody come down with babesiosis who got treated with 2 weeks of doxycycline right at the time of the tick bite. There's never a controversy if something is complete BS and there's nothing supporting it. When people are fighting about something, it should be a clue to people that that's a reason to take notice and do your own research and figure out the truth for yourself, because chances are there's a kernel of truth in there. There's something that's making this controversy go on. And with the case of Lyme, it's more than just a kernel. The literature on this topic is exhaustive and it's unbelievable. And back in the day, I used to present like boom, 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 like slide after slide after slide of 10 studies, 10 other 10. How could it be so well documented and still be controversial? And then it comes back to this problem we have with the scientific process.
I want to go back to the treatment. What do you do when somebody does present with a bullseye or an EM rash? They don't always look like a bullseye, so we should also say that. They can be really faint, and like mine was really faint. I know you see more like that than you do the CDC standard. How do you treat those cases?
We treat Lyme rashes with 2 antibiotics. We usually use doxycycline as Zithromax for a month. And you say, why do we use both together? There's conflicting studies, but There are, dating back a long time ago, a few studies using Zithromax for erythema migrans, and they work better than doxycycline. Those studies came out of Europe, and then there was one study out of the US showed that doxycycline worked better than Zithromax.
Hmm.
And the US decided to adopt and follow that study. But we can't discount these other three studies that said Zithromax works better. So they don't work antagonistically. Most antibiotics, when you combine them, they're at least additive and sometimes they're synergistic. An additive meaning 1 + 1 = 2, synergism, 1 + 1 = 17. And very rarely do you find combinations of antibiotics that are antagonistic against organisms. So Lyme rashes are an opportunity to keep people from getting sick. It's almost like a blessing to see it because
Hmm.
if you get sick without it, you don't know, and it's going to go on to later stages. So I figured we have this opportunity to keep people from getting sick. Let's treat them a little more aggressively at the beginning to save them years of hardship and horror going forward. And so we do that, doxycycline and Zithromax for a month, and then have people go off for 2 to 3 weeks, and then do several cycles, which we call pulses, of other antibiotics. And that part's a bit individualized depending on explaining the different options that are available, but usually
Sure.
tetracycline-based therapies with other things. And that is designed to get at the stragglers, these persister forms. So persisters, I can't stand the name personally because it sounds so unscientific. Persister forms. I mean, who came up with that? But it just means forms of the organism that you can't kill with the antibiotic that persist in the test tube. It's like
Yeah.
a percentage. It's very hard to kill. And when you go off the antibiotics, there's some data like out of Northeastern. Not all the studies show that pulsing works, but there's at least one study where they were not able to kill Lyme with one continuous treatment with ceftriaxone, which is the IV medicine for Lyme that we don't use in the office because there's a couple of studies at least to show that it's no better than the orals. It's no better than doxycycline, and it is more risky. So that's why we don't use it. There's that study from Northeastern showing that when they couldn't kill all the Lyme in the test tube, and they did intermittent therapy, they could kill it. And it's counterintuitive, you would think, right? You would think that if you stop and start, it's just going to develop resistance. But one of the things about disease-causing spirochetes is they have the inability to develop antibiotic resistance. They can't actually mutate around antibiotics. They have this inherent ability to, with Lyme bacteria, to stop growing, make these persister forms, kind of wall themselves off in these round bodies and stuff like this. But they don't have the ability to actually actively, mutate. It's like no short-term memory. Every time they see the antibiotic, take it away. It's like, oh, hello, I never met you. Like that.
What about your version of treatment versus what I would call the extremely poor standard of care that I got, which is, I did have the rash. I was in the blessed category, but not blessed because I didn't get to see a doctor like you. I was given 3 weeks of doxycycline, and as everybody knows, I went on to heart failure and many other problems in the next 5 months. So, what is the actual standard of care?
According to IDSA, it's a few weeks of antibiotics, and if you do get relapsed symptoms or chronic symptoms, they put you in the category of post-Lyme syndrome. You say, what's post-Lyme syndrome? It just happens to be the exact same symptoms as Lyme. And you say, is there data that people have isolated Lyme bacteria, evidence of Lyme bacteria like PCR from people with post-Lyme syndrome? Yes. The NIH even did a study where they put uninfected ticks on people with post-Lyme syndrome, again, quote unquote, and some of the ticks got infected from feeding on the blood. These are clean ticks that grew up in the laboratory.
Mm-hmm.
So I think post-Lyme syndrome is a ridiculous construct that people have made up to explain the chronic nature of these illnesses. And it's hard for doctors to believe stuff. But the thing of it is that these organisms are by nature really fastidious. It means that they can't isolate them in bacterial culture media. They can't grow them well. And if you let a dog get Lyme, you inject the dog with Lyme, let the dog be sick for a couple months and try to grow Lyme bacteria from the dog's blood, you can't grow it readily at all. It's very, very rare. But if you treat the dog and the dog is sick, the dog gets better. What is true is that host adaptive forms of these organisms are very, very different than the forms that are in ticks. They have to really change. They change their basic structures like total 180 to be able to survive in a mammal versus in a tick. So the culture media that are used in ticks are in no way, there's no reason to believe that that culture media would work for the host adapted forms that are present in mammals. So when they grow them out of a tick or they grow them out of a test tube, they're in these spiral forms. They look like the classic, spirochete. But when they find them in mammals, they never find spirochetes in the blood in them. So when they're under attack, they change form. And antibiotics can attack them, the immune system can attack them, and that's kind of how it works. So they only find spirochetes in like autopsies or in tissue sections in kind of immunoprivileged sites. So things like collagen isn't really well perfused by blood in the immune system, and they find spirochetes like aligned on the collagen sheets because the immune system can't get in there so well, so they don't really have to change form much.
So we talked about a tick bite with no symptoms and no rash. We talked about how you treat when there is a rash present to prevent the onset of millions of symptoms. How do you treat? And I know you probably hate this question in a way because it's not the same for everybody. But if somebody comes to you after they've been sick for a while, you discover that they have Lyme, Bartonella, whatever else, how do you begin treating somebody with a more advanced case of Lyme, of chronic Lyme? We should also just say, because we haven't sort of flat out said this, that Lyme can be chronic and there should not be any question about that. There's so much data to support that. So I'm talking about a chronic Lyme patient coming to see you for the first time, like me, like I did the 3 weeks of doxy. I consider that nothing because it fails so much.
Well, I wouldn't have called your situation chronic Lyme. You had 3 weeks of doxycycline. I mean, your stuff was a little egregious, It was like to not retreat you as you were spiraling downhill after 3 weeks of doxycycline. It's almost unimaginable,
Is that common that you hear my
Yes,
kind of story?
It used to be, but to be frank, most of my patients don't come in at the early stage that you came in at. Most of my patients have now these days come in because it's, have come in after they've been through the mill, like for a couple of years, gone to like 3 or 4 doctors, 5 or 6 doctors, 10 or 12 doctors. So the first thing we like to do is establish superiority of certain classes of drugs, particularly if there's Bartonella. There's a weird eccentric response where Bartonella patients, for example, can respond really differently to medicines in the same class. Like doxycycline and tetracycline are sister drugs. They're almost identical. And yet, I mean, you wrote about it. Tetracycline, you've spoken about this a million times. Tetracycline works far better for you than doxy ever did.
Way better. Way better. And in fact, I would say many of your patients have told me this over the years, that they were glad that you tried both for them and that one was preferable. Often it seemed to be tetracycline as well.
It's about 90% of the time tetracycline works better.
What's a Herxheimer?
What's a Herxheimer? Good question. A Herxheimer is a worsening of the underlying symptoms that happens when you treat some of these infections. And there's actually a few different types of bacteria that cause Herxheimer reactions. And spirochetes, which is a class of bacteria that Lyme is a spirochete and syphilis is a spirochete, and some other infections that people may not have heard of, like leptospirosis, relapsing fever. These are all these spiral-shaped bacteria that can change.
Dog owners hear a lot about leptospirosis, actually. So I'm glad you mentioned that because it's really dangerous for dogs. And they get it like humans in their backyards.
We have a patient in the practice who's a really nice doctor. And she got it by, she had a little cut, I think, on her toe. There was an animal, like a sick animal that her daughter was going to play with, and she ran to stop her daughter from playing with the animal. And the animal was like laying in a puddle, probably the puddle was like the animal probably peed in the puddle or something, and her toe just like touched the puddle, and she came down with leptospirosis. And leptospirosis, you don't really hear too much about like the chronic manifestations of that, but after that, she was actually never the same. You'll hear a lot of times when people have Lyme that they get these layers of infections, like, oh, I got sick in whatever, the end of elementary school, something weird happened. They don't know why. But I was fine after that. And then sick in junior high, and then I was never really quite the same. And then in grad school, the third hit, and boom, and then around. So I think that our bodies can take a lot, and there's just a tipping point,
What about 3 controversial areas of Lyme, which is congenital transmission, sexual transmission? Can your infant get it via breastfeeding?
I don't know why maternal fetal transmission is controversial. I mean, there's more evidence about that than for these other vector-borne infections that have been accepted to have transplacental transmission. And because Lyme has been such a hot button topic, they've put their, dug their heels in and haven't accepted that one.
Well, there's so much data on it. The problem is that nobody's looking at it. Like Sue Faber did such a great job of culling it and putting it on her website.
There are multiple cases of babies that are born dead from moms with Lyme, and then they found Lyme throughout the baby's body. I would say that's enough evidence. I just don't. What else does it take? It's just beyond. So that.
Well, I guess it's just so bizarre then that it's so infrequently acknowledged, and it's also so infrequently known. If ever I have said anything publicly about it or tweeted about it, I get people going, it's not congenital. Did you learn about congenital Lyme? Do you hear about it?
I remember we had one paragraph on Lyme. That one, it was like 4 lines. And the paragraph was wrong. Paragraph basically said you treat with 3 weeks or whatever of doxy, and if people still have symptoms, you do a spinal tap. And if it's in the spinal fluid, then you treat with Rocephin and IV ceftriaxone. And that's it. And if they still have symptoms, there's no other path. That's it. It didn't really talk too much about any of the controversial aspects. No complexities, no nuance, no nothing. Now the data shows it in people who have positive spinal taps, and many don't. Many people with central nervous system.
Well, do you recommend spinal taps?
Oh, I used to do them every Wednesday. Every Wednesday. Can you imagine me doing spinal
Wait,
taps?
did you physically do them yourself?
Yeah, I did them myself.
I literally want to die just thinking about that right now.
Yeah,
I can't imagine. I just can't even imagine.
No, this is me doing a spinal tap. Does that hurt? No. Does that hurt? No. One lady reached around and smacked me. She's like, if you ask me if that hurts one more time. I was like, fine. And her spinal tap, I remember, actually was positive. So
the only painless spinal tap you'll ever have, right here, Dr. Stephen Phillips.
I made it worse, to be honest, by going so slow. I never claimed to be skilled at doing the spinal taps, but I did do them. And then I would have people who had positive spinal taps that had elbow pain, negative spinal taps who were in a wheelchair. It wasn't corresponding to the level of illness. And then when the data came out showing that people with positive spinal taps, when they gave them ceftriaxone IV versus doxycycline in both studies, the doxycycline had a non-statistical edge, meaning that if the study was twice as big or twice as long or whatever, doxycycline probably would have shown to be a little bit better than the IV. It was not shown to be better. And these are the subgroups which the IV historically and stereotypically was supposed to work better, the neurologic people. And it didn't. So I was like, what am I doing? And that's what I was taught in school. And one of the many things that they taught us that was incorrect. And I stopped doing them on my own at a time when all the other doctors that were doing what I'm doing were still using the IV all the time.
Yeah.
And I just was like, this doesn't make sense. I'm going to do what makes sense.
What about sexual transmission? What about breast milk?
So I think there's enough data to support sexual transmission that to outright say that it doesn't happen is irresponsible.
Yeah.
But clearly it's an area that needs more study.
So what about breast milk?
But there's data that they can find PCR positivity for Lyme bacteria, PCR meaning the DNA, genetic material from Lyme bacteria. So there's no good studies to the way that have to be done, like rigorous studies to show if kids kind of convert to positive antibodies or anything like that after breast milk that I'm aware of. What I've always advised, look, I always say to my patients, breast is best and all that other, breast milk is a great thing.
Sure.
But if you have a known chronic illness and the baby came out looking healthy and everything else, I was raised on formula and I didn't have any childhood allergies or eczema or any of these autoimmune things. It wasn't until I got Bartonella that I was seriously a very, very healthy kid. And so I think it's just an individual kind of personal decision that women should make, and they should be fully informed. And then I would support their decision.
Do you think treating an expecting mom who has Lyme is reasonable, and would it possibly prevent transmission to their fetus?
I've treated about 25 pregnant women throughout my career, and at least that number have elected not to get treated, and they've had good outcomes as well, but they were previously treated people, So, I think there's a big difference between someone who's chronically ill that's never been treated and someone who's been treated to the point that they're well and they're happy and they're able to get pregnant and they have some residual symptoms. Those patients untreated, I've not seen bad outcomes. The only bad outcomes, I always say I've only seen 1.5 bad outcomes. You say, what is that? It's one person had a Lyme rash. They came to see me just after her Lyme rash. It was kind of a similar story with you. Like she had a Lyme rash, she got treated with short course of antibiotics, and then promptly relapsed. And then within weeks of treating her, she got pregnant. And I said, usually I don't. I told her usually I don't make a strong recommendation about treating or not. I explain everything, and I let we say it's like really your decision because there's pros and cons, and I'll explain the pros and cons. But with her, I made a strong recommendation to get treated throughout the pregnancy because I felt she was too close to the acute disseminated Lyme phase.
Totally understand.
Acute disseminated Lyme, it's not controversial. It's associated with a very high rate of bad outcomes. It's like 1 out of 4 babies are really bad outcomes from acute Lyme that's treated. So I did want to treat her. She moved down to Florida. The doctor's down there, so there's no such thing as transplacental Lyme. And it was just the perfect storm of like bad things because she moved and I only saw her a few times during treatment at the beginning. She moved and then the rest of the pregnancy was untreated, which was the majority of it. And her baby was very, very sick from the beginning. And then she kept in touch with the office and she told me that a year later, the baby was diagnosed with Lyme. And it was in Florida.
That's so sad.
And the baby was not even like walking around and doing all these things. So
that's terrible.
That one case, it was a bad outcome. The treated cases have all had good pregnancy outcomes. But I had one person who was disabled for a really long time, and she was seeing an infectious disease doctor who called me up and said, "Could you please, see her because I can't seem to get her better and do anymore." And I treated her, and she got well, and then she wanted to have a baby. So we treated her through the pregnancy, and the baby was born okay. But the placenta and the foreskin were both positive for Lyme and Bartonella. And I didn't even know that the patient had Bartonella. This is before I got sick with Bartonella. And
can you request these tests like pretty regularly? I mean, is this common that you could, and will most doctors say, okay, that's reasonable?
As soon as the baby's born, it's not really, the baby's not my patient anymore. So you have to work closely with a pediatrician. We don't do young pediatrics like that. So we worked with a pediatrician to do that testing. But yeah, you can request these tests. And I've requested placenta testing.
Interesting.
That's part of my patient still. The baby had this obvious evidence of Lyme in his foreskin and in the placenta, but he was a healthy kid. And the pediatrician did not treat him for a long time. And he was okay until he was 8 years old. And then he developed chronic Lyme and Bartonella when he was 8 years old.
What did that present like?
He developed a chronic multi-system illness and stretch marks all over his body and things like this. And
stretch marks are related to Bartonella. We should say that because I think it's an unusual symptom.
Yeah, and I would tell the pediatricians that tell their parents that it's just normal growing, that it's not normal growing. We see them in people who are young adults who stop growing them. We don't see them develop in adults with Bartonella. Like the oldest person I've seen to develop stretch marks was 32.
Interesting.
And the second oldest after him was like 22. It's really like a teenage thing. When patients come in and they're 20 years old and they're not growing, and all of a sudden, boom, they get covered with stretch marks like tiger stripes on their back. Then they go to the doctor and like, oh, you grew, and they didn't grow an inch. It's an insulting thing,
It's not widely known that is a symptom of Bartonella. So I'm glad that you mentioned it.
It's not widely known that they've actually isolated Bartonella DNA from these stretch marks. I have seen this so consistently on a regular basis. I almost feel like I have to hammer it home because I've had parents tell me repeatedly that the pediatrician said it's just normal. It's normal. It's not normal. I'm sorry. Yeah. There are articles out there trying to normalize it and say, oh, it's normal, and they're making a big deal about nothing. No, it's something to take notice of.
So how often, and what is the data about doxy failing in terms of doctors giving the standard of care, like 2 to 3 weeks of doxycycline with the early disseminated Lyme or the rash stage Lyme?
It's a study that you read, but the lowest failure rate that I've ever seen was when there was an article with where it was within 1 week of the rash. The rash was not accompanied by any systemic symptoms, so there was no evidence of spread, just the skin. And that failure rate was 5% in terms of chronic illness after that, chronic symptoms. The highest failure rate that I've seen was from Danbury Hospital, which is up the street from my office.
Yep.
They had a failure rate of 61%. Johns Hopkins did a study where they had a failure rate of 39%, and people had symptoms or functional impact at 6 months,
Mm-hmm.
39%. And then there are multiple studies showing in the 20-25% rate. A lot of times, if you hear this 10 to 20% quote,
Yeah.
I don't think that's actually accurate. I think the failure rate is probably closer to 20-25, not 10 to 20, but you do hear 10 to 20 a lot.
That is millions of people falling through the cracks and becoming chronically ill. We haven't really talked about our book, which we should. Just the whole premise of the book is how chronic stealth infections cause chronic autoimmune and neurologic and psychiatric diseases. We didn't yet cover the brain, but what does Lyme Plus do to the brain, and what does it do to the psyche?
People tend to differentiate neurologic from neuropsychiatric, and
Mm-hmm.
I always found that troubling and weird because it's the same brain. And if you're numb
Yeah,
in the part of the brain that causes you joy and you get depression, or if you're numb in the part of the brain that makes your arm numb, how is it that different? So I think the inflammation of the brain can cause both neurologic and neuropsychiatric symptoms. And that long-term inflammation, unfortunately, can contribute to dementia and cause dementia sometimes in a really direct manner. But these things are multifactorial. I don't want to make it sound like infections are the only thing that causes
sure.
everything, because
Absolutely.
there's so many exposures that we have in our lives that are not infectious exposures, but rather toxic exposures, because you can't explain the really unbelievably rapid increase in chronic illness over the last 40 years to just Lyme and Bartonella and other
Sure.
infections. These infections have been around for billions of years. So what else is to blame? We talk about mold, which is obviously a big contributor to illness, but mold's been around forever as well. And one of the things that is actually increasing in the population is heavy metal exposures. Harvard did a study that atmospheric heavy metals are up by over 700%. And it's not really a disputable thing. And that's like the most conservative estimate that I can find. There's other
Wow.
estimates that are higher. So if it rains into your crops and you eat a tomato, I mean, we get it from all different sources. Did you hear that recently about tampons having various heavy metals? Have you heard that in the news lately?
I haven't, but I'm not surprised.
That's been considered a very controversial area of medicine. It's been defaulted exclusively to alternative medicine doctors. I wrote about chelation from the perspective of cardiovascular disease only.
Yeah.
For one of my zero spin articles.
What is chelation?
Chelation is removal of heavy metals from the body, and the NIH funded this major trial with Mount Sinai, and it was published in 2014 called the TACT trial, TACT, because all these alternative medicine doctors were saying that chelation helped heart disease, and nobody would believe them. And when I wrote my zero spin article about it, it's a Substack newsletter, I wrote how I was so arrogant. So when I was younger, I thought, when you get out of med school and residency, you think you know everything. Doctors go one of two ways. Either they go in the way that they really do think they know everything, or they go the other way and they realize they don't know much at all. And science is huge, and we have to be humble and all that stuff. So I remember I had met this alternative medicine doctor, came up to me, telling me how great chelation was, and I was kind of rude. And I walked away. I was like, oh, thanks. Walked away, and I wrote about that in my article because I was such a jerk. And over the years, I started realizing maybe this is something to take more seriously. And when this article came out in 2014, instead of the medical community embracing it and say, wow, we need more study about this, like the Cleveland Clinic basically eviscerated Mount Sinai and said how the study should never have been done. It's false positives and, whatever.
Why do you think that happened?
The implicit biases that we all carry with us. I mean,
Yeah.
I can tell you that to think that scientists and researchers are not subject to the same biases that the person at the checkout counter is when you go to the supermarket or whatever, it's just silly.
But aren't there reasons for it to be more of a concerted, not so pure ignorance effort? I mean,
like the financial conflicts of interest?
like I'm thinking about Lyme, right? And it's not innocent. They know at the top of the food chain in medicine and science, they all know that it's chronic and they all covered it up. That's not even really debatable at this point. And so I'm asking the question, but it seems like there would be reason to obfuscate the heavy metals. The implications are not great. And then there's also, what are we going to do about it? Who's going to fix it? I remember Somebody at the CDC, off the record was talking about congenital Lyme and said, well, if we acknowledge it, people are going to expect us to fix it.
I mean, it speaks toward regulatory capture, which means when these agencies are supposed to be regulating these industries are actually captured and controlled by the industries they're purported to regulate. We're both very outspoken. We're not like little wallflowers. And I've always said that the EPA has been captured by the chemical industry and
Sure.
the FDA is captured by the pharmaceutical industry. They don't have our best interests at heart. And if you look at the funding structure for these organizations, it's so like blatant and in your face if they're getting money from these places to provide the majority of their funding. Like the FDA, most of its budget comes from pharmaceutical companies. Like that shouldn't be a thing. You shouldn't be funded by the people you're supposed to be regulating.
And a lot of those a lot of the officials at the FDA have gone on and worked for industry. And that's really,
a revolving door.
It is a revolving door. And that is highly disturbing. I saw somebody made a little meme about it, and I was horrified to see just how many of them, including Scott Gottlieb. There was a whole number of them. Now he's the head of the board of Pfizer, but he was the former head of the FDA.
Yeah, my brother Jeff, may he rest in peace. He started alerting me to the corruption probably like 9 years ago. Because I was so doe-eyed back then. I really believed it. I was like, I thought Lyme was the only dirty area of medicine.
Yeah.
And then when COVID hit and you realize like all these unbelievable, egregious lies and unnecessary deaths and smearing of early treatments and denial of long COVID and trying to say it's functional neurologic disorder and all these things.
Yeah.
Like,
what were we going to call the book? Pandemic of
Lies.
Yeah, that's the one. I mean, it really was the pandemic of lies. Now that you brought up COVID, I think you and I watched together in horror the similarities. We sort of had an early inkling that this was going to have political, medical overlap. And I don't know if either of us knew it was going to be as much of a crime against humanity as it ended up being and continues to be. But I assume that a lot of people who got COVID have come to you with long-term problems. And I also wonder about whether some of them are being treated and you're discovering that they have vector-borne diseases that have reactivated, that have caused these long COVID symptoms.
And I was treating COVID with multimodal regimens. As soon as another, regimen came out, I would investigate it and use it if it had merit. And they were working. And we really had an amazing outcome with treating COVID, and none of my patients that were treated within the first 5 days were hospitalized. One of my patients in the first wave got treated and had a mild case of COVID, and I thought she'd be fine because my other patients were fine. They weren't developing any type of long-term after effects.
What were you doing back then for treatment?
So I was using doxycycline, I was using ivermectin, I was using all the herbals. I was, keep in mind also that ivermectin had a clear smear campaign. I don't know if the viewers know about these types of things, but I have experience using ivermectin for 10 years before COVID was a thing. And it's a drug that's been around for a very long time. They won the Nobel Prize for it, its discovery in 2015. And direct quote, it's been described in the medical literature as astonishingly safe. And it's been billions of doses have been given out. So when they had the gall to demonize this drug that's been described as a wonder drug, I was like, they just have no limits on what they can do. And
that's right.
That's why I actually started writing Zero Spin. I wrote the first thing, it was called Ivermectin on Neutral Ground. There's no paywall on it because I'll never put a paywall on that.
It was a great piece. People should still read it. And they should also look up the Zoom call that was released by Dr. Tess Lawrie between her and Andrew Hill. And he worked with a bunch of well-known public health agencies like WHO, and he was forced to cover up the very positive data on ivermectin. And she challenged him about, you're just going to let people die and suffer needlessly? And he was like, unfortunately, yes. I mean, that was kind of the bottom line. And people should go and watch that conversation because I think it's really hard hearing all this horse-paced propaganda for the last couple of years to say, oh, this could possibly have had some benefit or still have some benefit.
As someone who's been prescribing ivermectin for 10 years, like I literally, at the time, I had a patient who was so sick that she was 6 years old, a little kid, and she had spent her childhood like bedbound. They took her to the NIH, they took her everywhere, and she finally got really functional with ivermectin. It was the last like piece of her puzzle that got her off disability and to the workforce and full-time employment and everything. That was her drug that really, really helped her. And the mechanics of how ivermectin works, as an immune modulator, whatever, probably outside the scope of this talk. But suffice to say that I have just a very long track record with the drugs used, know it inside and out, its safety, its multiple interesting effects on the body. And it wasn't just the patients that were trying to get it for COVID. They denied ivermectin for her. And she's like, I'm going to get disabled again. What's going to happen to me? Blah, blah, blah. And people should know about that whole horse paste episode, the timeline. Everything happened at one time. It was completely in sync. All the pharmacies stopped approving ivermectin at once, like virtually on the same day. The FDA came out with that tweet virtually on the same day that it was horse paste. It's not a veterinary drug. It's a drug that started in human medicine and made its way to veterinary medicine, just like penicillin did.
And we should say that it is the reason it was discredited, most likely, is because it is cheap and generic and it is off patent. And they also, I think that one of the rules of having an EUA for a vaccine is that you can't have an effective therapeutic or you can't get an EUA for a vaccine. So were several things at play. But even after that, there was a huge push to develop a new drug, and that would be Paxlovid, that is on patent.
You couldn't get an EUA for Paxlovid or anything else. It wasn't just the vaccine; it was everything.
Right.
They couldn't any effective therapy, and by the time they started smearing ivermectin, there were already over 75 trials of it. So they actually had made up this story that a hospital was so overrun with overdoses of ivermectin that they couldn't treat gunshot wounds. And it went completely viral and everybody picked it up. It was like front page of everything. And when they looked into the story, it was completely fabricated. They called the hospital. They never had a single overdose on ivermectin. And it turned out that the doctor who gave the quote never even worked for the hospital.
So evil. This was so highly orchestrated and this was so highly detrimental.
But isn't it hard to believe? Like if people are hearing this, they must be thinking, is there proof about that? I mean, I have links and all, and then ivermectin article, put links everywhere. You say, oh, you're such a conspiracy theorist. Well, when conspiracies turn to be true, you're no longer a conspiracy theorist. You're just someone who's pointing out a conspiracy that actually exists. I mean,
yeah,
actually there. So I am unfortunately, I've always been critical of large corporations and people do things in bad groups. The Holocaust happened by people working in a group. It was a bad time. And that's an understatement of the world. But people will do things when they're in groups that they won't do singly. They frequently will not behave. They usually it's hard for a person to lose their moral compass when they're acting on their own. It's very easy to do so when they're acting and as part of a big corporation that's multinational, multi-billion-dollar corporation, and they just kind of screw people over right and left. It's hard to trust again. I mean, we've been lied to so many times on such a repeated basis. You don't even know where to get reliable information.
It's true. That's why we're talking here today. So where are you now with treating acute COVID? This is another question I get very frequently, and there's a lot of confusion about it.
So there are a few things. I mean, it's been like a little mini epiphanies as I go along. So if you remember, we had this conversation. So I was treating COVID with the early treatment options, and I was having these great outcomes. Remember, I had at the beginning only one person that developed chronic bad illness, what we thought was long COVID. And so there's really two parts to my answer. One part is if I just talk about the one person who had chronic illness after COVID. So she had a mild case of COVID. And before that, she had a case of Lyme and Bartonella, and her Bartonella symptoms consisted of like a tingling neuropathy, nothing horrible, but not great. I mean, but abnormal nerve sensations. And after she got COVID, it turned into this like absolutely searing neuropathic pain that she couldn't even take a single step, and she was completely disabled. And we thought it was long COVID. What else could it be? It happened after COVID. And I treated her with whatever I could for COVID, lots and lots of things, and nothing worked. And I said to her, I wonder if the character of Bartonella somehow changed after COVID. And she was very much against the idea. She's like, I don't think so. But her case is such that she wasn't actually treated with some of the stereotypical drugs for Bartonella. She never took Bactrim, which is a type of antibiotic. So I said, let's just humor me and we'll try to treat with some Bactrim. And we gave her Bactrim. Her symptoms that we were kind of semi-attributing to long COVID just exploded on Bactrim to the point that she actually couldn't tolerate it twice. and it was an exacerbation of this horrible pain in her legs and in her body. And the third time was a charm. She was able to tolerate it. We had to go up really slowly, and she completely got her life back. And she started
Wow.
playing competitive sports, and she traveled in a great dream vacation to Italy last summer, or the summer before. I'm not sure which one, but she's gotten her life back, and she's back to her good old self. So, but I figure
That's
if that
great.
can happen to somebody who had a known case of Bartonella, what is happening to the people with asymptomatic Bartonella, which is so common, just like Lyme in the population? Are they becoming activated for the first time? And that was the
Yeah.
genesis of that. But then the other thing is that some of this I haven't even spoken to you about. So we had spoken, I remember, in the first wave or maybe the second wave about why were my patients doing so much better than other doctors who were treating early on with things like ivermectin and everything else. We were using similar regimens, and my patients were doing better. It came out some published evidence about how COVID is so immune dysregulating after the acute infection, and how long does that period of immune dysregulation last? And it occurred to me that maybe it's like letting the genie out of the bottle, because you would get these things. It was often where people would get COVID, they'd start to recover, feel fine, and then 3 weeks later get hit with this like multi-system illness and get, POTS, which is postural orthostatic tachycardic syndrome, and MECFS, chronic fatigue type presentation, everything else. But there would be this delay. And what happened during that delay? And if the immune system is dysregulated, could it allow for the reactivation of infections? And is that why the delay happened? But my patients were different because they were getting chronic and repeated courses of antibiotics. So not only were they treated with early treatments for COVID, they were also, after that was done, we were giving them follow-up rounds of things like doxycycline and tetracycline and zithromax and other things to keep these in, to actively treat them for the infections for which they came to the office. But that also keeps the genie in the bottle. So during the period of immune dysregulation, they don't have a chance to develop these things. So you've heard about that case that was published, I think, in April, a documented case of what they thought was long COVID, and they found molecular evidence of activated Bartonella,
Yes.
and they treated the person for Bartonella, and her long COVID resolved.
Exactly. So it really begs the question, what is long COVID? We know COVID can be chronic. We know that COVID causes damage. We know it causes all kinds of dysregulation and stuff, but it's also, I think the thing that's being missed the most, in my view, and that's being talked about the least, is that it reactivates other underlying, possibly asymptomatic or minimally symptomatic infections. There was a lot of press about how it reactivated EBV. But in that conversation, for which there is no standard of care, right? I mean, there's no antiviral
And
that
there's such an emphasis on it. It's such a de-emphasis on the vector-borne stuff.
exactly.
At least with
Yeah.
the vector, I'm not saying it doesn't reactivate EBV, but again, the treatments for it are miserable and they're toxic, like really very toxic. And the treatments for Bartonella and Lyme are not very toxic.
In the face of Lyme and Bartonella, forget COVID. Prior to COVID even being a thing, EBV got activated in the face of those infections. And, in my experience and talking to you and lots of patients over the years, you treat their Lyme and Bartonella or whatever else, and their EBV stabilizes and goes down and becomes the normal level.
If you can subdue infections to the point that the immune system comes back online, like if you had a choice, like pick a normal immune system or pick a good antibiotic, choose the immune system every day of the week. But if you can, like I said, I think that it's not just Lyme, it's not just Bartonella, it's not just EBV. It's probably a lot of chronic infections get reactivated. But what's the low-hanging fruit, and what are the things that we can treat effectively? And these are the ones that we can treat effectively. I do think, and doctors do disagree about this, about how long the virus persists, but there is good data of active replication for a very long time, like GI tract biopsies. So what is COVID doing when it's in the body, actively replicating for a long time? The thing is, there's also really good data about other viruses chronically replicating in the body. Like I did an article about inflammatory cardiomyopathies and the infections behind them for Zero Spin. And they find all these viruses in heart muscle tissue when they do biopsies, but they also find Lyme. Like, is it causative or is it just there, is the question. Do you know about that study where they did, it's called like recently acquired dilated cardiomyopathy? So they had this study where people had this heart condition that my father, may he rest in peace, had from. My father did not die from heart failure, but my father had a viral, what they thought was a viral meningitis in the mid-70s. It was probably Lyme at the time, because Lyme, when it causes meningitis, presents very similar to a virus. It's a type of meningitis that does not kill people usually and goes away on its own, even without treatment. And it was right after then, like a few months later, that he started getting weird heart palpitations, which got worse and worse. And after about 10 years, he got atrial fibrillation. And after another several years of that, he started going into heart failure. We took him to the top cardiologists, all the major New York City teaching hospitals, and he went to end-stage heart failure, and they wanted to give him a heart transplant.
Yeah.
Anyway,
Wow.
all from him, and he got better and blah, blah, blah. So, and he never went into heart failure again. They did this study where they went in and did heart muscle biopsies on 110 patients that had his exact condition. And even though they find lots of viruses in patients like this, they found Lyme in 1 out of 5, and they treated them, and their heart failure went away in all these patients. But they also made a point to say in the study that 61% had negative Lyme tests, so around 2/3 of the patients had negative Lyme tests, and none of them had Lyme arthritis, and none of them had Bell's palsy. I think one had AV block, which is atrioventricular block.
Yeah.
They didn't have the stereotypes for Lyme, is what I'm saying. So if you don't know that Lyme can cause dilated cardiomyopathy,
Right.
words, but a specific type of heart failure, if you don't know that going in, these people just wind up on heart transplant lists, and that's they go through with heart transplants, like our
I
friend,
mean,
Neil Spector.
it's a crime.
Yeah.
When I went into heart failure, before I met you, nobody knew why. It was like, we don't know why. You are in heart failure. And I remember what the cardiologist said, you have the heart of a 70-year-old man. I don't know why. He called me like really late on a Friday night. It's like, and then I remember you talking to him after you treated me and I was getting better, and he repeated the echo. I don't know if you remember all this, but
I
he
do. I
was,
remember sitting there from the side of the road. I don't pull over.
yeah, yeah, thank you for that. I appreciate it. He was very receptive, and I think it informed, he has a lot of patients that come, that New Yorkers that spend weekends outside of the city and have a super high level of exposure. And I think you really changed his mind. He was one of the great doctors that I saw along the way in terms of just being very open-minded, wasn't dogmatic. He was in the mainstream. And I really appreciated that he was willing to listen and learn and take this very seriously, and followed up with me a whole bunch to make sure that I stayed stable and good. And I luckily, thank God I did. You talked about the long COVID stuff, but day one, a patient calls you, I have COVID, I just tested positive and I feel pretty sick. What do you do? How are you treating?
If one of my patients has COVID, which just happened recently, I offer patients a multimodal regimen. I don't offer them just one thing. For example, one of the things that I offer people is doxycycline. And the reason I do that is because doxycycline has 3 levels of data behind it. It has, at first it had computer modeling predicting that it would work against COVID. Then it had actually cell culture data showing that it inhibited the virus in the cell. And then it became part of some human trials that's been published.
Is it antiviral along with being anti-inflammatory and antibacterial?
I mean, even Zithromax has some antiviral activity. The fact that an antibiotic can have some antiviral activity, or an antifungal can have some antibiotic activity, or vice versa with an antiparasitic, it's not so surprising.
But I think it's important to point it out, because every time I say tweet about doxycycline, because you have to be like, okay, drugs can have multiple mechanisms of action.
Right.
And it seems like not to be the first thing people think.
So yeah, fluconazole is antifungal, and it has good activity against Lyme in the test tube, and it's been part of a published human trial, and we've been using it for years. But anyway, I give doxy, or I offer doxy. I do use Paxlovid, which is in contrast to some doctors and some of these groups that take COVID very seriously. I think that people are so turned off to Pfizer that sometimes they don't want to use any product that comes from them or whatever. I'll take a decent product if it works. The problem is it has there's a lot of rebound associated with it. So I will actually offer people a second course of Paxlovid to go longer. Now that it's FDA approved, it's not EUA, we can treat with a second course, and it would be off-label. Doctors are allowed to use things off-label. So, but I don't take it lightly, and I don't do it like a cowboy.
So you're saying you do 10 days.
I would offer people. Some people, a lot of times, insurance companies are not covering the second 5 days, and that's $1,700.
My perspective is, and I'm sure you and I both agree on this, like anything to avoid a long-term chronic illness is worth doing if possible.
But also we offer people metformin, and I do like the metformin data. Metformin is a diabetes drug that's been around for a very long time, generic, very inexpensive. has a generally very good safety rating. And we don't use high doses of anything. I do think it's like, I analogize it to treating blood pressure. Use, moderate doses of multiple things. I mean, studies on treating blood pressure using one drug with a very high dose does not work as well and is more toxic than using multiple drugs at lower doses. So I use metformin at 500 milligrams twice a day, unless somebody is of low body weight, then I only use 500 milligrams once a day. If someone weighs like below 110 pounds. And we do that for a couple of weeks, and we check safety labs. That's the key thing I want to make sure, like that we do the regular blood counts and chemistries and everything else. And I also check D-dimers 5 days in and look to try to risk stratify people. And if there's a particular concern, I'll also check cardiac enzymes to make sure. I haven't personally seen COVID myocarditis. I know it's published, so we check, but I haven't seen it. I have seen COVID vaccine myocarditis in 2 patients, but never COVID myocarditis. But we see tons of patients with very elevated D-dimers shortly after COVID, and we want to further risk stratify them, and we do sonograms of their legs and make sure they don't get any clots. It's like a lot to go through, but how many people's lives do you have to save that it's worth a little bit of, annoyance? Because I know a doctor who's in this, just a couple towns away, who's a young, healthy guy, and he had a stroke 2 weeks after COVID.
Yeah.
It's like Russian roulette. So anyway, so Doxy and Paxlovid and metformin, I still do use and offer people ivermectin. Insurance almost never covers ivermectin now. And those are, I'd say that's the core protocol for what I use these days, plus the whole litany of herbal and supplement things, zinc, vitamin D, vitamin C, and melatonin, and glutathione, and NAC. And I happen to like nattokinase quite a lot as an anti-clotting agent, but there's not really good data on it yet. No one's really, there's data that it dissolves spike protein, like in a test tube, but in terms of acute survivability from COVID and everything.
You did treat my dad with that regimen that you just mentioned, doxycycline, metformin, and 10 days of Paxlovid, and some of the supplements that we had on hand, and we could quickly messenger over to him. And he did fabulously well. You've treated him a couple different times, unfortunately, that he seems somewhat susceptible, but he did really well on that regimen. And he didn't have any overt signs of long COVID or lingering stuff with the first infection before we had all this information about. Also, I remember the first time you treated him, he also had the flu and he couldn't tolerate more than 5 days of Paxlovid. And I remember saying, would you consider taking a second round? And he was like, I can't handle it. He handled it very well the second time. He did great, but it was quite something to try to advocate for him while he was hospitalized for a couple of days, trying to get them not to give him remdesivir, trying to get them not to give him steroids, trying to get them to give him a couple of days of doxy till he got out. So was able to do these things with your help, but it was not easy. And I had a tremendous amount of pushback, and I had to keep calling an administrator. And you remember it was incredibly stressful. Hospitals make a lot of money giving remdesivir, and it's not that safe. It's not that effective. WHO recommends against it. And it actually was responsible for the death of one of my friend's parents. So I just thought, we can't do this. We just got to get you out and get Dr. Phillips to treat you from home. And you did, and he did well. So thank you for that. But that was really instructive to me to watch his recovery. And he also turned negative really quickly on that regimen, like 3 or 4 days. The first time that he got COVID a couple of years ago. And by the way, I should say he was highly vaccinated at that time. He had just had a booster like 4 to 6 weeks prior to this infection. So a lot of stuff that made me very upset about his case. I mean, he got super sick. He was positive for 17 days. Scary. It's a really long time. Right. And, we know that sometimes informs whether you're going to get long COVID, the longer you're positive.
Yeah, I don't understand the thinking of doctors that treat these infections in ways that are so kind of lost their way from like the basic wisdoms. You never would let like a cut on your finger get to the point where it's like gangrenous and disgusting and ready for amputation before treating. And
right. It makes no sense.
They let COVID like, I don't know, you can just do without treatment for a while. It does boil down to Russian roulette, and you just don't know what's going to be. And because of that, when I look at the risk-benefit ratio, I say, and as long as we do it safely, why would we take the risk of having somebody develop long-term chronic illness afterwards, or even a short-term horrible chronic that turns chronic, like a stroke or a heart attack or something.
I like bromhexine as well.
Yeah.
Do you use that?
I used to use it all the time at the beginning, but
Mhm.
less so now. It's hard to get, you can't get it on the drop of a hat.
Oh, it's hard to get. You're absolutely right. I remember you and I ordered it from some strange pharmacy back in 2020 when we heard about it and we had the bottle translated. I like it, and I read a lot about it over the last couple of years. It's just such an interesting drug. I know other doctors who like it a lot and are using it for COVID. Even I know a doctor who just treated her daughter, and that was one of the things that she thought was helpful. So
Definitely not against it at all. It's just it's as far as over the counter things go, it's expensive and really hard to get.
So the last question I have for you, you're one of few doctors who seems to take both COVID and the COVID vaccine seriously, COVID vaccine injuries. It seems like this has become the great divide. People either think everything is the virus, any symptom that you have after COVID is long COVID, but they don't take into account vaccine injuries. And it seems like the people who are really, really upset about the vaccines, it seems like you're on one team or the other. So what do you think about the comparison of the virus, the vaccine? How do you know what's what? And how do you feel about the landscape?
So when the vaccine came out, I didn't know anything. Like none of us knew anything. The only
Sure.
thing that I knew that we both knew that they were saying some lies about the vaccine early on, because when we interviewed, I forget the gentleman's name, very nice guy that had told us live on a Facebook interview as in preparation for the book release, that the top tier government officials were estimating that the maximum duration of the COVID vaccine would be 6 months. And
Oh,
then
Ali Nuri. He's a molecular biologist and he went on to work for the Biden administration and the energy department.
at a high level, and and then Fauci was exact same time was saying 2 years. I'm like, wait a
Yeah.
second, 6 months, 2 years, that's a huge disconnect.
Well,
And
he
then
said he had just hung up with the head of the FDA's vaccine program, who told him that like the day before or a few days before. So it was straight from the horse's mouth that he
right.
gave us that information. And then we're hearing, yeah, this is going to last for a long
So
time.
I knew that there was these really very important discrepancies from sources. So I stopped thinking. I stopped really believing, taking it from like the spout, sort of, just like taking a run with it. I had to like start doubting.
Sure.
And then when it came out, people would ask me like, should I get the COVID vaccine? And I said, well, I'm not advising you not to get it because I don't know anything about it, and COVID is bad. So if you're high risk individual, I think that you should get it, and that's my official stance at the time. And I did see quite a lot of side effects. Thankfully,
Yeah.
they were mostly acute side effects, but have had in the practice in the hundreds of patients that wound up in the emergency room feeling they were going to die, just feeling
Yeah.
really, really horrible.
Do you
And
remember the physician that we both know who works at a hospital here in New York that got the vaccine early because they're, on the front lines at a hospital and said that they felt like they were going to die?
yes. But the thing is, they normalized that. And they said, good job. That means the vaccine is working. So before the COVID vaccines, I was always pro-vax. And in large part, I had not seen, I can count them on like one or two hands, where I'd seen crazy vaccine reactions over a career of like, at that point before COVID it was like 25 years almost. And now it's like another 5 years, 4 years,
Sure.
whatever. But since the COVID vaccine, I've seen hundreds of cases. And my first patient with myocarditis came out with what we think is myocarditis now, because she went into heart failure within like she had horrible symptoms from hours of the vaccine. I went into heart failure a few weeks afterwards, and but nobody knew about myocarditis at that point. And then when it came out that it can cause myocarditis, it was supposed to be 15-year-old boys, and she's an adult female. After they knew about myocarditis, I had he's 50, but a very young 50, very like athletic, vibrant 50-year-old who got myocarditis after the vaccine. What he went through was so crazy because his wife's an old patient. He's not a Lyme patient. And his wife's an old patient from like a decade ago. And she like said, can you just please see my husband? It's a mess. No one knows what to do with him. It's horrible.
Mm.
And his story was that he had done fine with the first two vaccines with no side effects. Booster. 2 days later, he got crushing chest pain, and his doctor told him it was not related to sleep it off. And then sometime later, after exercise, he had a very bad chest pain with the emergency room, and they said, you're having a major heart attack. They gave him a catheterization. His coronary arteries were clear. And they're like, well, it can still happen. It could be a heart attack. And not a single doctor, he told every doctor that it happened 2 days after the booster, they all said it's unrelated. I'm like, what clairvoyance do they have that I don't have? Like, how could they know? Like, when you speak to like people that say it's either a long COVID, it's the vaccine, it's this, everything deserves an individual investigation for the circumstances of the patient. And he
Yeah.
had these symptoms 2 days after the vaccine. So I got him a cardiac MRI, which can discriminate between a heart attack and myocarditis. And the radiologist called me and said, your patient has myocarditis. So he did not have a heart attack. He never did have a heart attack. He had seen probably 15 doctors. They all kind of, I guess, drank the Kool-Aid, so to speak. I mean, they just followed this narrative without questioning it. I was so kind of like just dumbstruck by the whole thing, how people
Yeah.
can't question things, and we both question everything. Like, is something wrong with us, or is something right with us? Like, I don't know sometimes. Don't you
Yeah.
think it's a minority? I mean, it seems like
Yes, I
the
do.
just accept things
I
without
think we're in a
questioning.
minority of people who question things and
Who's
who
minority?
actually do our own diligence on stuff. I was seeing stuff early, and if you were to say anything about it, it was like you were smeared, discredited. And very recently, there's been this new campaign. I saw Ashish Jha on Chris Cuomo the other night. It was like the most nauseating interview of like pandemic of lies, just still falling out of his mouth, saying, yeah, there were a lot of vaccine injuries, and we made the decision to downplay it and cover it up so that we didn't create more vaccine hesitancy. That's not informed consent. I read an article about it on the NIH website not too long ago, just saying like it's a medical imperative to do that.
It's fundamental to the practice of medicine as informed consent. So to have lost their way in such a blatant and egregious manner is just, it is kind of scandalous. But yeah, so in terms of how to answer your original question, though, like, how do I respond to, like, is it COVID? Is it the vaccine? Is it both?
Mhm.
It does strike me as annoying because on, X, it's so polarized. Like, people are
Yeah,
so stuck in their one view. They can't realize that, hey, this is a really bad virus. It can do a lot of bad things to the body. And
yeah.
this vaccine is not all it was cracked up to be. It's far more dangerous than they let on. It's far less effective than they let on. And at the beginning, it was like career suicide to say that you're going to be criticized and ostracized and everything else. But now it's so obvious to everybody that there have been problems with this particular vaccine that I don't think it's a mystery anymore.
Do you hear as frequently as I do that this single-handedly made a lot of healthcare workers and physicians just question everything, not trust any
Yeah,
of their public health agencies?
I've never had so many conversations where it spontaneously came up how they can't believe anything anymore. I mean, it's come up in all sorts of iterations,
Yep.
from like what's going on in CME, the CME continuing medical education that we get is
Yeah.
so slanted. Doctors are kind of taught like by rote, by memorization. They're not really taught so much a nimble way of thinking, like how to think. But it's worse than ever. It's more and more kind of compartmentalized and guideline driven. You can't question the guidelines. I mean, well, the guidelines are written by these people who are heavily influenced by conflicts of interest, and it's just
They're not
this.
treating patients either. I mean, that's the other thing that's crazy about it.
So it's a swamp.
So how can people find you?
Yeah, so Zero Spin is zerospin.substack.com. People just search Zero Spin in my name.
That will save lives. I highly recommend subscribing to Dr. Phillips' newsletter. It is so much important information that is missed by the mainstream. You set a doctor appointment, you get 5 minutes of information. This is very comprehensive. And I know a lot of physicians also deeply appreciate your wisdom.
So it gives the opportunity to go into these things in depth. But yeah, we're in Wilton, Connecticut, been around for a very long time, been in practice since 96.
Are you open for business right now? Are you guys taking new patients?
We're taking new patients, sure.
Great. Terrific. Well, people will seek you out as they always do. I can't thank you enough. It was great to talk to you again.
You're Dana.
Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.